Welcome to Quality. This is your host, Arjun Venkatesh, where we're exploring quality in emergency care. Today's episode is the next in our venous thromboembolism series. It's part of our National Emergency Quality Network VTE initiative, where we're trying to improve the quality of PE care. I'm joined by the co-lead of that work, Dr. John Sather. And today our special guest is Dr. Reinier Van Tonder, who is from my shop at Yale as well, and is both the medical director of a 60,000 visit ED, but also the ED point person on our PERT team, our pulmonary embolism response team. And so he's going to bring a couple of different perspectives to today's podcast. And for our listeners, we're going to take a different angle than usual. Often we talk about policy topics or QI topics, but we have a lot of frontline clinicians who listen. Those could be physicians, APPs working in EDs around the country, be them rural or academic shops. And one of the things that's interesting about emergency care for PE is it's a lot different today than it was a decade ago. It's not just about, did you get a dimer or not? Did you do a CT or not? And did you give them heparin or not? We know from our earlier podcast in this series that there's a lot more nuance to treatment, risk stratification, and that our work in the ED has gotten harder as patient complexity has gone up. And so today we're going to pick a challenging case, walk through it, talk through sort of the evidence-based decision-making around that case, but really something that we hope can help people at the bedside caring for patients every day. So welcome, Reinier.
Right, thank you, John Rod. Pleasure to be here.
Yeah, so instead of us giving you the challenging case, I thought what we would do today is we'd let you give us your challenging case. And so I know you had one recent. It is a perfect example of all the things we've been talking about in the Equal Network around PE care. So why don't you kick it off for us, almost oral board style? You can give us the stem, start walking through the case, and then hopefully we can help people learn a lot through this experience.
Perfect. Happy to do that. Okay, so case starts ABM general, I guess. 70-year-old patient. The patch is in the field STEMI alert. So patient had syncope at home, some chest pain, some shortness of breath, apparent EKG with a STEMI. Patient arrives to the emergency room, immediately met by the cardiology team and our attending, and looking at the EMS EKG, maybe a significant new right bundle, right axis deviation, not an entirely clear STEMI, maybe some inferior ischemia. And at that point, our patient goes into cardiac arrest, PEA arrest on the monitor. John, what do you think?
Wow. So I guess on one hand, I say we got our diagnosis in the field STEMI, new right bundle, maybe some ST elevation. I'm assuming cardiology is at the bedside.
Correct.
I think we got our plan. Let's get this guy to cath lab. The PEA arrest seems a little unusual. You had him on the monitor, I presume, so it wasn't VFib. Seems like an unusual arrest. Correct. And I also know this is a PE podcast, so I'm going to ask you the question that would be running through, I think, our minds. What's the role of presumptive treatment of PE in a patient with syncope, maybe some ST segment elevation and cardiac arrest? And did you and the cardiology team that was at the bedside consider TNK? Thrombolytics?
Yeah, no, that's a great question. We definitely considered it, but we had a more powerful tool that helped us to answer that question. Is there any tool that you could potentially apply to help us to see, to kind of differentiate this patient? What would you potentially do for that patient?
So I think, obviously, I know where you're going because I know your other area of expertise is ultrasound in the ED setting.
Yeah.
So I'm going to guess you had the ultrasound machine in the room before the patient even got there. And when this patient arrested, it was one of the first things you did. You put the probe on his chest. What did you see?
Yeah, no, perfect thing. Great answer. So RV, bigger than LV. Typically, it should be about 0.6 to 0.9 of the size. So this RV is big. The right ventricle free wall is not moving, but the apex is excessively moving. Call that a McConnell sign, highly specific for pulmonary embolism in our population. We didn't see any right heart thrombi. We saw definitely what's called a TAPSI, so decreased mobilization on M mode. So all the features of big acute RV strain on our bedside echo. what do you do with
And so
that?
Rainier, let me ask you about that, because you've been talking more and more about how point of care ultrasound can help us with risk stratification on PE. And I'm sensitive to the fact that we've got a lot of listeners who, maybe they traded me at the same time as me and they feel like confident in echo, but TAPSE really wasn't a thing, right?
Yeah.
Or maybe they trained before as widespread a use of ultrasound. And so they've got some echo skills, but it's still work in progress. The key part that you just described, though, is you can figure out if there's some sign of right heart straight in that cardiac arrest patient with almost one view and without a TAPSE, right? And so how do you do that? Because I think that's I want folks to feel like no matter what ED you're working in, if you've got an ultrasound machine, how could you in one view figure out what you figured out?
Yeah. So the apical parasternal long axis view is the easiest view to obtain. I think it's like most things that we do, the more you practice, the better you get. We have amplitude of patients with chest pain, shortness of breath that presents to our EDs, that point of care echo can be easily performed under easier circumstances than this patient. And once you do that frequently on that parasternal long axis view, you'll easily start to see the size differentiation between the right ventricle and left ventricle. And that was very obvious here. This right ventricle is much bigger than the left. And then you had the typical other features that will come with more experience. But initially, just as simple as that, the fact that that RV is bigger than the LV in this setting of this patient is a telltale sign.
That's helpful, right?
Maybe,
So one view and you're there. Yeah.
let me ask maybe a harder question. And again, we've talked about this before, but I don't know how widespread bedside ultrasound 24/7 by ED or access to it by ED providers is in our nationally. If you didn't have that echo, how would you feel about this case? You didn't have the ability to do ultrasound.
Well, I think the two leading diagnoses, in terms of STEMI and pulmonary embolism, both at this point would probably be the correct treatment. Could be a thrombolytic therapy, and so TNK would be in our setting, and we use TNK. It would be a weight-based dose, and it would be the same dose, one dose for both STEMI and pulmonary embolism. So I think it would be very reasonable to provide that at this case.
And then when you were obviously you had the ultrasound, you had better confirmation. Did you worry about contraindications? Did you sort of explore whether there might have been a reason not to give the TNK, or do you assess this to be obviously a life-threatening situation in which there's almost no contraindication to TNK?
Yeah, I think, considering that the patient is in a cardiac arrest, we have access to the chart. So I guess we could have done some fact checking in terms of use of anticoagulation and other medication. But in this case, given the hemodynamic instability of presumed pulmonary embolism or cardiac arrest and pulmonary embolism, TNK was definitely indicated.
And how did the cardiologists feel about that decision? Were they in agreement?
Yeah, based on the EKG finding, the syncope event, the echo finding, it was everybody was in agreement that the most likely diagnosis was pulmonary embolism.
All right, so tell us what happened. You pushed the TNK. What do you expect?
So we had subsequent continuous CPR event. The patient was also started on a norepi at the time, and after 2 rounds of CPR, we had return of spontaneous circulation. We had recurrent pulses and blood pressure lower, systolics in the 90s, but we had return of spontaneous circulation. Took about 2 cycles after TNK to see that effect.
And can I ask you maybe a minor question, but it comes up often. Crystalloid resuscitation in these patients, good, bad, or indifferent?
Probably not a good thing in pulmonary embolism. The RV is stress, and you're gonna increase that RV stress by increasing more fluid to that at this point.
So caution with the crystalloid in these
Definitely.
cases.
And in this case, we had to intubate the patient because we had cardiac arrest at the time. But if you are dealing with a massive pulmonary embolism and you are considering intubation, of course, the longer you can hold off, the better. The peri-arrest or the peri-intubation management in a massive pulmonary embolism is fraught with a lot of danger. And so if you can hold off intubation as long as you can, that would be prudent. But in this case, the patient was already intubated.
And is this one of these sort of, if you know you need vasopressor support, start it as early as possible?
Correct.
So would you, start pressors before you intubate?
Correct. Yeah. And norepi would be is our pressor of choice in this setting.
Now, a lot's going on. Obviously, you're performing a procedure at the bedside. You're thinking through a case, which I'm sure was quite stressful. You're making a pretty crucial decision to give the TNK. You're intubating the patient. You're resuscitating the patient. What else are you thinking about in terms of next steps?
Yeah. So in our system, pulmonary embolism with cardiac arrest, we have a pulmonary embolism response team. And based on the criteria, of course, this is the highest risk criteria of a patient that we can have. And so that response team will then be activated. And we would then get the response from pulmonary critical care, interventional radiology, and also in this case, because it's our highest tier, we would get our ECMO team activation and our CT surgery activation. That would be our highest form of response for a patient, and typically need a response and an answer within 30 minutes of a patient presenting with a full pulmonary embolism response.
And are you doing that in this case the moment that probe goes on the chest, or are you waiting for CT confirmation of the diagnosis?
No, I think as soon as we recognize syncope, RV strain, TNK, the alert went out.
And it's not like, tell me, like, I think people often wonder with these PERT alerts. So when a PERT alert goes out, is it sort of like people may have experienced with trauma or stroke, where all of a sudden some team descends and, takes the patient and whisks them away? Or is this different than that?
It's slightly different. We have kind of a two-tiered response, so if a patient has a diagnosis of pulmonary embolism and they have any evidence of RV strain, but they are perfectly hemodynamic stable, they don't require impressors, that would be kind of just a modified alert. And that just gets us in our system a pulmonary critical care individual and interventionist. In our case, it's interventional radiology, and they would then weigh in the team. For a full pulmonary embolism alert, because we are considering to offload the RV with ECMO if we can, interventional radiology will do thrombectomy if they can. And then in the cases where a surgical embolectomy is indicated, CT surgery will be available as well. So those are based on the risk stratification after the diagnosis. The team members are activated.
It's interesting. So really what it comes down to is swiftly diagnosing a clot as the cause, and then doing everything within your power to expedite removal of the clot.
Correct.
And interestingly, we have a really good analogy that I think in emergency medicine we're quite comfortable with, which is the STEMI paradigm. And so much so that you already had a cardiologist at the bedside who was prepared to remove any obstructive coronary artery disease finding. But really, you quickly transitioned to finding another type of expert
Correct.
who, beyond the TNK you gave, could actually remove that clot.
It's an important point, but I mean, man, are we there as a specialty? Like, I think this is where there's this real disconnect, right? It's like you said, with the second that patient came in and you think it's a STEMI, like everybody's on board. Get that patient to intervention, get the clot out. Increasingly, I think we're there with stroke. I got a patient, LVO, get them to thrombectomy, get the clot out. That I don't know that I I've always felt that same feeling of tempo around care and intervention for PE. And I imagine there's going to be some people listening now who are going to sort of ask I'll play devil's advocate for them. They're going to ask the question, well, like, is this really as real as those? Like, does it really going to help the outcomes? Or is this just one of those situations where, because we have a fancy device, we're just trying to do more of these procedures? What do you say to them?
Well, I think to me, sometimes I use the analogy of if I go home and my kitchen sink is plugged up, I can maybe drip some Drano slowly in there over time and may help things over time, or I can just stick a little device in there and pull the hair plug out, and the drain will flow forward. So it makes kind of intuitive sense. I think. I agree with you. Maybe the time sensitivity is not quite the same as the brain and the heart muscle, but because of this obstructive process, it makes intuitive sense. And now in the era of catheter-directed thrombectomy, where we have significant data, like 800 patients in a US-based study, that have the major adverse reactions are minimal, less than 1%, 1 to 2% of any device-related complications. We have, and with significant improvement in cardiac parameters, symptoms, pulmonary hypertension later on. We see that significant improvement of devices that now can be deployed safely. I think that paradigm shift is definitely occurring at this point.
And I think you brought up a really interesting point that sometimes gets lost. I think we often think about the catheter-directed therapy or CT surgery if needed as a life-saving event. And oftentimes it is, to extract a big clot, causing severe RV compromise. But failure to do that has some long-term, even if the patient should survive, really long-term impact on morbidity in terms of the things you mentioned. So there's kind of two roles for large clot extraction, which is one, life-saving, decrease mortality from the PE you've diagnosed, but longer term is decreasing permanent RV dysfunction, pulmonary hypertension, and the sequelae, which can really be life-altering. And yeah, it's hard to wrap your mind around that at the moment. You're in the room saving a life, but we got to kind of help work with our consultants who can provide a service that may have longer term impact that we're thinking about at this moment.
Yeah. And PE is, from a diagnostic standpoint, we have all the decision rules to help us with D-dimer, age-adjusted D-dimer. So diagnostically is a challenge, but therapeutically, not every patient is the same. You get from can go home on a DOAC to getting on ECMO and get a thrombectomy or surgical. And the spectrum is really wide, and therefore, the expertise and the teams that's available to help navigate that patient into that risk stratification and then treatment stratification is just a huge benefit, but also a significant, I think, paradigm shift, especially the last few years with the use of catheter-directed thrombectomies.
Let me ask
you.
You've
worked at, I was going to say, you've worked at community hospitals before, and we have our own freestanding ED here. And for folks who are listening, who might be at a shop that doesn't have a PERT team yet, but has, an ICU, or they transfer patients to a different ICU, how do they translate this down? What should they be thinking? What should they be doing?
Well, I think definitely on the diagnostic scale, the power of point of care ultrasound, in addition to your undifferentiated chest pain, shortness of breath, syncope patient, to be correct with the diagnosis or narrow your pretest probability significantly, that's a huge adjunct. To be able to risk stratify the patient and in a certain group of patients be able to provide thrombolytics can be life-saving. But then also to kind of work to find out when you risk stratify patients and they potentially are in an intermediate high or very high risk group, to have some kind of transfer agreement or agreement with a center to be able to, just like a stroke center or cardiac catheterization center, kind of work to get that program where you can get help. We do send teams out to initiate ECMO at certain in our systems of our sites, but also we have implemented in some of our community sites a AI generated radiology system where our interventionalists and our pulmonary critical care gets notified of a central clot as soon as the CAT scan is done. They look at the imaging and then they reach out to the attending or the emergency room doctor at that site and says, listen, we just looked at that imaging. We can help. What can we do to support your patient?
And I think that's where you see, again, the analogies with stroke management, acute transmural ischemia management. I think the PERT Consortium is doing a nice job of sort of understanding that there needs to be a support system out there. Because if this patient's in the community, you've got the ultrasound, as you mentioned, you can make that diagnosis, you can intubate, resuscitate, give the TNK, but really the definitive therapy that we've just talked about and the definitive ongoing support if the patient should become more critically ill or rearrest really needs the patient to be transferred. And I'm willing to bet that not every community hospital that may not have that expertise has the relationship yet. But I think we'll, again, work towards that as we have done so well with stroke centers, regional stroke centers, regional cardiac catheterization centers. But let me ask you another question. You threw the term ECMO around. It clearly was on your mind. Again, the moment this patient has PE arrest, you put the probe on and the RV is strained and you're pushing TNK. Why think about ECMO now? Why is that part of a PERT response now? Don't we have so much we need to do before? We got to get a CAT scan. We got to get him to IR. Why are we? Is any CT surgery really going to surgeon want to call in the middle of the night to get ready for ECMO on these patients?
Mm-hmm.
Explain why that featured in your early decision making.
Well, the point is to offload the RV. We want that RV to come out healthy of this. So we want to, any process that can offload it, either removing that obstruction or letting that RV rest while we intervene, is beneficial for the long-term recovery of the patient. It also gives us a window to get catheter director embolectomy appropriately deployed, or have the experts of a surgical embolectomy potentially weigh in if a surgery would be indicated. So it buys you time while the RV is offloaded.
All right. So what happened?
So this patient then ultimately had successful ECMO cannulation, successful catheter embolectomy, was in the ICU for approximately a week, and then on the medical floor for a week, and then in rehab. And I just looked at his chart yesterday at his 6-week neurology follow-up, neurologically intact, came to his own visit by his private vehicle, and is doing well.
Amazing.
That's an amazing story. Yeah.
So we kind of glossed over quickly. So I'm imagining you got him at some point stable enough for a CAT scan.
Correct.
What did that CAT scan show?
It showed bilateral significant clots with a persistent RV strain on the CT as well. And so subsequently went from CT to the IR suite.
So he, because of the PERT team response, was able to go directly from CT to clot extraction. And then tell us why he needed the ECMO.
Well, he showed evidence of end organ damage. He had multiple presses on board at the time. His lactate was increasing. They were working on the right lung when he had persistent hypotension. So they activate the ECMO to improve perfusion, offload the RV so they complete the extraction procedure.
Let's go back to that CT for a second, because I'm guessing there's some people listening right now who are wondering one of two things. One, did we have to get that CT in the ED? Like, why couldn't they just get it upstairs in the unit? Or the second question is, did you even really need the CT? And if you're worried, this is a really sick patient, about them being unstable, and you've already sort of given them to TNK? Was it too risky to get the CT? How'd you sort through that?
I think we also run a extracorporeal CPR program. I think it's been, once the patient is on the ECMO circuit in the CT ICU, it's very difficult to transfer the patient, get these studies. There's high dose anticoagulation that comes along. So they typically want to know how the brain looked prior, and then want to see if there's any complications. The patients often, as in this case, had CPR. So they want to know if there's any evidence already of rib fractures, pleural fusions, other traumatic injuries. So they often would like to have CT imaging done before they go to the CT ICU. So it's beneficial from that standpoint. But I think too, the CT imaging helps the IR attending or the interventional attending plan to see what they can get out, how much, what the approach would be. So I think that's very beneficial for them.
Yeah, I can't imagine a patient being sicker from this diagnosis, and it's really remarkable, sort of the really incredible team effort and the swiftness of the diagnosis, using fairly simple bedside adjunct tools. The thing that gives me pause and concern is this patient was lucky enough to have his event in a city that had an institution and a provider and an entire system built around delivering that care. And, what if this gentleman was on vacation, had the same event, but in a setting that didn't have those systems in place and available to them? And I think that's something, again, I mentioned the PERT consortium, but I think that's something nationally we need to be working towards, making sure that wherever you are with your high risk PE diagnosis, that you can get this level of amazing care so that the outcome can be the same.
Yeah, I mean, I know it's a taboo word now, but we always talk, the word we always use in the stroke world, in the STEMI world over the past 10, 15 years has been regionalization. And now people, when they hear the word regionalization, they think it has something to do with hospital consolidation or mergers and acquisitions and corporatization of medicine, but it really doesn't. What regionalization was in these cases has really been around this idea of thinking about, for time-sensitive illness and injury, right? For the big things, MI, stroke, cardiac arrest, PE, maybe sepsis, I don't know. How do we build systems of care around communities so that all patients can get access to that life-saving essential care? And I think PE is a place where we could probably do that work. And we've got a lot of good models to go off of in these other diseases. And it doesn't have to be, a boogeyman bad thing about mergers and acquisitions, this, that, and the other. It's actually about trying to figure out, how do you figure out who those sickest PE patients are that need this level of critical intervention and get them to it as fast as possible.
Yeah.
But I think, hopefully with Equal, that's the exact kind of thing we're trying to do, is get EDs motivated, help them put in some of the foundational building blocks around PE care, but then really working towards, on a more national scale, how do we build these systems of care? Because these are actually the things that also show the value of emergency medicine and the value of our care, right? There's a lot of people really have been still talking about that ARC report about diagnostic errors in emergency medicine and missed PEs and things like that. But, what we sort of glossed over a little bit was that you guys made an incredible diagnosis in this case at the beginning. It is easy to anchor on a STEMI, not to have made this diagnosis, and then to sort of made the subsequent diagnosis that this was high risk and needed these interventions too. And so these are sort of the stories we need to be telling about what we do in the ED.
Yeah, I agree.
Yeah, amazing story and great outcome.
So thanks for joining us. This was an awesome episode. Really appreciated doing this. Hope to have you back. Maybe we'll do another master clinician case again in the future. But thank you for joining, and thanks everybody for tuning in, and look forward to future episodes on our VTE series.
Thank you, Arjun. Thank you, John.
Thank you, Reinier.